this is Roger Green, host of the Surfing the MASH Tsunami podcast. Today, we're offering 5 conversations from episode 24, our discussion about looking back at EASL from 6 weeks after, plus a 5th discussion, which is a review of the question of the week from conversation 23. We've got Jeff McIntyre and Pharmanist CEO and founder Mathieu Pétichine for the interviews, and Mike Patel and Jose Willems for the discussion of the QOW. The second question to Jeff was what the implications of the takeaways he describes in conversation 3 will be on GLI and other patient advocacy groups. To Jeff, the trend towards more efficacious drugs, different modes of action, and integration into the broader metabolic scheme makes patient advocates more valuable players in clinical trial design process, particularly when coupled with the FDA's increasing focus on diversity in trial populations. This will become particularly important because today, the major use of incretin agonists like semaglutide and tirzepatide is in anti-obesity, where payers are frequently declining to pay for the drugs. Advocates like GLI will be pivotal in ensuring that patients who need MASLD drugs will still get the drugs they need, particularly at earlier stages of fibrosis, or if you will, advanced fibrosis, not early cirrhosis. This discrimination may allow patients to receive incretin agonists during the pre-fibrosis stage based on diabetes and anti-obesity indications, and reserve the fibrosis drugs for patients with more advanced MASH. The entire scenario of early metabolic, later MASH treatment with different agents is at least 4 to 5 years in the future, he feels. In the meantime, Jeff sees the need to advocate for underserved groups in the population, while at the same time laying the foundation for the longer-term case. In this context, he sees the United Nations General Assembly's side event that Jeff Lazarus covered in Season 5, Episode 22 as an exciting and vital event. As we've discussed over the last several episodes, EASL Congress 2024 was really a seminal, empowering event for the MASH and MASLD community. Listening to these 2 dialogues with Matt Pétichine and Jeff McIntyre gives you a sense of the many different ways that players could look at this and the impact that it will have on their businesses or their not-for-profits going forward. It's an important set of issues and I think really intriguing. So just sit back, listen, learn, absorb, and when you're done, join the conversation in our LinkedIn discussion group. So how does any of what you observed there change what you're doing going forward?
Jeff McIntyre.
It allows us to work on the problems and the challenges that we have only been able to theorize about. So we can begin to get definitive answers. The Boehringer medication especially is something that allows us to implement the lessons learned from what we went through with Rezdiffra, and even more so with what happens with Novo in this way. I think that that's a significant thing. This allows us, the FDA's recent, as I referred to earlier, their recent guideline on incorporating more diversity into clinical trials. That's going to be a pain for companies. So they're going to have to be intentional in ways that they haven't necessarily been before. But if done correctly, as I said, with patient involvement, that can have a real payoff in terms of patient access down the road. It can create relationships. It can open doors. You can kind of have access to these communities now that previously hasn't happened in the past. And so to us, it defines the challenge much more better. We stop working out of a mode of anxiety and worry and consideration of all these possible things. And now we actually have tangible challenges that we can get answers for.
Okay, so there were 2 late breakers about drugs to treat MASH. One was fruxafermin, which I mentioned, and the other late breaker was actually about tirzepatide, which is on market right now, if not indicated, and also has some pretty good results. So I'm wondering why you're envisioning the issue more in terms of sema, whose results will probably not be as good as the tirzepatide results, and then survodutide as compared to tirzepatide. Is that about Lilly? Is that about it not having the indication? What's that about exactly?
Honestly, when you look at sema, I think it is the fact that we also have this conversation going on about anti-obesity medications in the U.S. right now as well, and about reimbursement for that. I think any conversation about that has to have that. It's not necessarily in the context of that, but it has to have that conversation attached to it. I think there are concerns that if we do get sema, and thank you for my pronunciation with just saying sema on that we could actually end up with kind of a cooling or chilling effect in terms of some of the medication approvals for liver disease specifically. And so we don't want to see that happen. We want to continue to push for specific medications for especially F1, F2 in this way. There's so much emphasis on the fibrotic state, which is part of why the Boehringer medication I think is really exciting in this way, is that if we continue to evolve in that way. Dr. Sanyal, in an interview I did with him for Global Fatty Liver Day, when I asked him about 10 years from now, what is a victory we'll be celebrating? What is the challenge we're going to have? And he says he thinks in 10 years' time, we'll be on the cusp of possibly getting rid of liver fibrosis as a disease. And that's glaringly optimistic, but I think it shows where the trend is in this. And if you combine that then with the anti-obesity medications, that's kind of where my focus is coming from on that.
So if we're going to get rid of fibrosis, and first of all, I take the 10 years as being somewhat optimistic, given the original predictions about how long it would take to eradicate HCV. And here we are 30 years later, not having done it yet. So I appreciate both halves of that statement. But to me, eradicating fibrosis always had two pieces to it. It seems to me that number one is, can you put your foot on the hose, thereby stopping or slowing the rate at which patients flow into fibrosis? And then can you get better drugs to treat them once they get there? You can see that both pieces are in place.
Yeah, absolutely. What's the quote from Archbishop Tutu, that at a certain point you have to stop pulling bodies out of the river and go upstream and see what's pushing them in. And so we have some of that going on here. And so that's where some of our optimism is coming in this, I think, is you're beginning to see that approach. And as I said, if you get the AOMs in there as well and get those reimbursed, then we're beginning to have, granted, it's come about in a fairly fragmented way, but you're beginning to have something come together. And that's where the shout out to now working around metabolic as opposed to non-alcoholic, I think, has really been promising and effective for the field in that way, as we're able to now gather these various different components and address it in that way.
Yeah, we agree. I've become increasingly convinced that while not every element of the rollout went exactly like I might have hoped, the name change in and of itself makes a lot of sense. And not just because of MASLD, but for exactly the reason you provide. And what makes that even more interesting to me personally, by the way, this is my interview, it's yours, but what the heck, is that the real benefit of SEMA as a simple GLP-1 is that will be easier to get used for diabetes and obesity. And if you talk about how to put your foot on the hose as compared to treat fibrosis, slow the rate of patients going into fibrosis, that's going to get done in diabetes and obesity. That's not going to get done with, I don't think you're going to see drugs indicated for F0 or even F1. I think what you're going to see is drugs indicated to treat the metabolic parameters, and that's going to be where the foot goes on the hose.
Absolutely. The goal here is to support and help patients, period. And we know, often said, it's cardiovascular events that are the big concern for just kind of simple fatty liver disease for F1 and F2 in that way. And so by having these AOMs out there, we're really beginning to help with that issue in that way. And so if we can help resolve that by any means necessary, which I agree with you, I don't think it's going to be a lot of F0, F1 sort of indications for this, or prescriptions, if you will. But if we get that resolved, then that allows us to focus a little bit more so on the more advanced states or where some of the other pain points may be in this.
Okay, so people complain that Americans use too many three-letter acronyms, so I'm going to put a definite. AOM is anti-obesity medication, and I'm going to suggest to you that the major issue may actually be AOIs, if you will, anti-obesity indications for medications that originally got approved for diabetes, right? I mean, I think that's probably more of what we're looking at, but not that it matters at the end of the day. Well, here's the sequel. The sequel is we're now going to start to look at some of the dual agonists going for their first approvals in obesity. We don't have a true metabolic AOM right now.
Yeah, I totally agree with that. But we can see that light at the end of the tunnel, potentially.
Yeah, I mean, I recommended 5 years ago to a couple of the dual agonist companies that they should hit obesity first, and at least one of them took me up on that. So we'll see what happens. But that would then become a true AOM. Not that it would necessarily get any more use than the multi-indication medicines where obesity is one of the indications. But right. So, but I think all that makes sense. So what does that mean for what you do next year or over the next 3 years?
Yeah, that's a great question, Roger. I mean, in some ways it is, we continue the fight. You know, it is an elevated version of what we've always done, is that we continue to push with great passion and fortitude to get more patients screened. I think there are at-risk populations and marginalized populations that we haven't even begun to have that conversation with. And so we've got to get more people screened for liver disease. I think we've kind of held off in the past a little bit about trying to come up with the perfect non-invasive, if you will, and we're well past that need right now. We've got to get people out of the house that's on fire, whatever it takes. And if that's a multiple screening indicator, that's fine. I think we found that. Because now we have a medication that if they do screen at something more advanced, we can establish a clinical pathway for that to happen. I would be reft to say that we're working on these kind of two levels. One is that sort of serve the immediate need of the patient, get people, that individual, that family, that community screened and begin to get them on the clinical pathway. For GLI, that's national and international in that way. For us, I think also we have, as I said, the potential of the readout in November for Novo. And so we want to take and examine what are the lessons learned from Resdifra, see what that happens with that, how we can best support that, how we can best kind of get that out there in the context of the anti-obesity medications. And there could be some kind of chicken and egg stuff that goes along with that, which, God help us, isn't too dependent on the American election necessarily, but could end up being influential there on that as well. And then I think the other thing that's important for us is that we really had a great event at the World Health Assembly with EASL, and working with EASL on trying to get liver disease and MASH on the agenda for the General Assembly next September is a huge priority for us. And it is not just so we have a shiny thing at the UN, but this allows us then to do more of the grassroots and grass tops works with what ultimately will be kind of the champion countries that we identify. That doesn't just help serve these underserved areas, but also then establishes a pipeline, if you will. It's almost like it establishes a foundation by which then we can have regulatory conversations in those countries to be able to move, better medication. And none of this happens without the screening on that as well. So it's going to be a busy year of both meta and micro.
Okay. I'm wondering where MIDI is. If we've got meta and micro, is there a MIDI somewhere in the middle? But forgetting about that for a sec, just two more thoughts as we get towards the end of the time available. Number one, the other conversation that's part of this episode is with Matt Pettigene of PharmaNest. And one of the things we talked a little bit was the ability to think about this a little bit like HCV and over time to move towards phenotyping. Not something we're going to do immediately. And that would allow for better dedicated use of drugs, probably better health economics, and easier to get things approved or paid for. I'd love for you to comment on that.
I will give the caveat that I don't know a ton about that. Immediately go off from that. But I think that is absolutely a valid goal. I think it's something that we have to be working towards in this. I think I've been more focused on the immediate than I have on the phenotyping of this.
Yeah, you kind of have to learn to walk before you can run the 100 meters. I get your point.
Yeah, and it's been more dictated by the circumstances here as well. But seeing that as a logical and even perhaps logistical next step, maybe even not next step, but the next step in this totally makes sense to me.
So here's another next step that actually I wasn't thinking about before I've been listening to you, so it just kind of popped into my mind. If you start identifying countries to deal with regulatory, do we think that'll lead to a fairly common result everywhere you do it, or will the results be different enough that you can then go to the second level countries and say, well, you got option A, which is what they're doing here, or option B, what they're doing there? Do you think all this evolves as a single global model, or do you think it starts to splinter a little bit?
Oh, no, it definitely splinters. No question about that. It's kind of like the Monty Python quote where the crowd chants, we're all individuals. It's one of those things where there is going to be a common thread, but we have seen, for instance, if globally people look to the FDA generally acts first. After that, it goes to the EMA. Generally, Europe is close behind that. After that, it begins to disperse out. And what we've seen, if you will, and I don't think I'm talking out of turn when I say this, if you see the regulatory models for, say, Latin America, if you look at Mexico and Brazil, then if you can get through those regulatory systems, and they tend to follow a good bit of the lead, although they're very much their own independent entity. They tend to, take into consideration, I'll say, what's happened with the FDA and EMA. And if it's good stuff, then that sets us up better in those positions. But then you tend to see a little bit more of a domino effect through the rest of Latin America. And it's not that there can't be issues that pop up in Uruguay or Argentina or, Paraguay or something, but that it makes it easier for us to make the case in that instance. I'm kind of talking out of both sides of my mouth for your answer there, Roger. We are all individuals at the end of the day. So yeah, I think it does transfer in that way, but it doesn't mean that we don't take the individual country any less seriously in that instance. And then what we take from there, we're able to talk, with Philippines. China's kind of a thing on and of itself, which has to be engaged kind of in a separate way. And we begin to run into different issues there. One of the things that we've seen is for the acclaim that you and I have given over the benefit of the nomenclature change, roughly a third of the world's population isn't using that nomenclature right now. They're using MASLD and have a bit of a chip on their shoulder, frankly, about it as well. And so we've got to be able to engage those countries on their terms and in a culturally competent way that engages that disease, in the way that they talk about it. But the heart of it is still going to be metabolic, and I think that that's where the biggest promise of this is.
So then one more small question, right? You called what used to be known as International NASH Day Global Fatty Liver Day this year, which I think was, as much as anything else, as you explained it to me, in recognition of this MASLD thing, that if people are calling it by different names, then you can't just pick, as a global patient advocate organization, just pick one nomenclature, even if you'd like to pick sides. Forget whether you would or not. Over time, does the word metabolic work its way into the title of the day, or does it stay focused on on fat in the liver? Would you guess?
My guess would be probably not. I wouldn't say it as an impossibility, but I mean, it's a theoretical more so than anything else. When we talk about patients, or talk to patients, I mean, as you referenced, I was just in South Carolina. I spent the past 5 weeks up in a small Appalachian town there. And if you say metabolic to folks, they're not going to quite understand, or at the very least, they're not going to make the connection between metabolic and liver, if you will. I mean, people don't make the connection between diabetes and liver necessarily. And so if that were to happen, we'd really have our work cut out for us in this. And we find that fatty liver disease is something that is descriptive, it's simple, it's easy to understand. I know there are those that disagree with us, but our patients reflect to us that it's not stigmatizing. And in fact, we've seen that reflected also in Asian countries where it's the issue is that it's the opposite of stigmatizing. It's actually an ideal that they're trying to live up to. And so that's why we've stuck with fatty liver disease is it opens the conversation, and it opens the conversation in a way that is kind of where and how patients talk about it.
And then to go back to a phrase you've used in this conversation, metabolic then becomes the meta discussion.
Yeah, very much so. I mean, and I feel like we're trying to find a solve for liver disease, and it's for MASH, MASLD, MAFLD, whatever it is. It's that fat on the liver that goes fibrotic and then cirrhotic, and it's that process. And once we talk about metabolic kind of without the other context, I think a lot of folks then begin to get a little confused by that it can be confusing. But if we talk about fatty liver, that's a very concrete, operationalized sort of thing that people can actually visually imagine much more easily. It leads to an easier conversation where we can go, this is that, thus get screened, get treated,
Okay, so we're 2 minutes past the end of the time you told me you had available, and that answer led to a question. So if I can ask you one more, and I promise this will be the last one. Does that extend to MetALD as well?
I don't know, honestly. I think the Met part of MetALD will probably not be recognized as much as ALD still is for patients. I think that's a fairly clinical designation right now. I think people are still going to see, we still suffer from the stigma of alcohol disease on the liver, and liver disease is being related to alcohol, period. And so the notion of it there being a metabolic sort of thing, just for patients, I don't think that's going to stick a whole lot. I think it's an important clinical designation. I think it's going to be very important to the science and to the researchers in that way. But for patients, that phrase alcohol liver disease is going to be so prominent as to the fact that there's a metabolic aspect to it. It'll help them when they're in the doctor's office maybe a little bit, but it's not going to be a determining factor.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Also, remember to answer our questions of the week so that you can have a chance to hear panelists discuss them and be part of that discussion and recognized on the program. In our next episode, Maru Ranello joins Jorn, Louise, and me to discuss the recent expert recommendations on resmetirom paper published in CGH. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.